Okay, welcome again, everyone. My name is Skip Zimmerman. I'm the coordinator for the Disaster Mental Health Program at the New York State Office of Mental Health. We're really happy that you could all join us for another installment in our series of special topics trainings for disaster mental health responders and practitioners. It is my pleasure today to introduce Dr. Carla Vermeulen to you as your presenter. Dr. Vermeulen is an associate professor of psychology at the State University of New York at New Paltz. And she's the former deputy director of the Institute for Disaster Mental Health. In addition to training disaster responders and trauma workers, she teaches courses on disaster mental health and grief counseling. And she researches the impact of disasters and other stressors on emerging adults. So with that, I would be happy to turn this over to Carla, and I'll ask you to take it from here.
Got it. Okay, can you hear me okay?
Yeah, we sure can.
Awesome. Thank you, Skip, and thanks to Paula and the rest of the team there at OMH. I was just looking back. I think I've been doing trainings and curriculum development with OMH since like 2011 or something like that, which makes me feel like an old person, but it's always been a great relationship. So always happy to kind of connect with OMH personnel who are doing very important work out there in the field. So we're going to be talking today about supporting older adults in disasters. As Skip said, you can put comments or questions in the chat at any time. I am not going to be trying to follow the chat myself because then I totally lose track of what I'm trying to say, but Skip is authorized to jump in at any point if there's anything time sensitive. Otherwise, I think we should have some time at the end for discussion, which could either be in the chat or if people want to, go live in audio at the end. That will be our plan. Okay, so what are we going to be talking about today? So basically 3 sections. I'm going to talk really briefly about risk factors that are recognized for all disaster survivors, regardless of age, other demographics. Just make a couple of points to kind of set things up for context. Then we'll be talking a bunch about what is it about older adults during times of disaster, before, during, and after disasters, really, that does make them be considered kind of high needs or a special population. And then we will talk some about what you can actually do to help people, build into your planning, just thinking about what might occur in your community. And we do have some resources at the end, some links to other websites and documents and things like that. So we will share those at the end. Okay, so first of all, just what are some of those recognized risk factors for all disaster survivors? And let me kind of preface this by saying, throughout this training, I'm going to be making a whole lot of generalizations about what we kind of understand sort of at the population level or the typical older person. But I also really want to acknowledge there is no typical older person, right? Everyone is an individual. They're all going to have their own strengths, their own resources, their own challenges and vulnerabilities. So please keep that in mind. What I'm going to be talking about is kind of general guidelines, but the person you are talking to is the person you are talking to. So always wanting to respect that for all survivors. Okay, so what makes people vulnerable? We've sort of moved away from using the term vulnerable more to special or high needs populations, but these are some of the kind of characteristics or experiences that are recognized across all disaster survivors in terms of making people at risk of, when we say more extreme reactions, as I'll come back to later, that does not necessarily mean a clinical level reaction like post-traumatic stress disorder or serious depression or something like that. It just means people who share these characteristics, often they're just going to struggle more. And they might be going into the disaster with more, keep saying, even though I don't like the word vulnerabilities, I keep coming back to that, I realize. But I think just thinking, we used to sort of use the phrase, and some of you might have heard me say this in other trainings, that disasters don't discriminate. I do not believe that is true. I think that there is plenty of evidence that it's often the people who are already dealing with the most challenges or who have the least to lose, who end up losing everything and then have a harder time coming back from that. So just in terms of thinking about for all disaster survivors, but how that applies to older adults, we certainly know getting a higher dose of the disaster experience is not surprisingly associated with worse reactions. And that can be, how intense it was, particularly if the person felt that their life was in danger or that loved ones' lives were in danger. That is certainly going to set them up to have a harder time to kind of process what they've been through. If they went through an extended period of disruption or suffering, some disasters last a minute, some like floods, wildfire recovery can last a very, very long time, or people can sort of never get to that new normal. So that, and then just how close was someone to it? Were they like immediately on the site, or were they kind of distanced from it, or even just observing it through media? So that idea of this kind of dose-response relationship, just like in medicine, bigger dose, likely stronger effect on people. And certainly for many older adults, even just thinking about where in the US a lot of disasters occur, hurricanes in particular, right? They are generally in the South. They're in Florida, they're in the Carolinas, they're in Texas. They tend to hit areas that a lot of people might have retired to. So you tend to have larger populations of older adults in some of those more vulnerable areas geographically, which means you're going to have a lot of people who are going to maybe get that big dose. And, I'm sure we've all seen, we got really lucky with this year's hurricane season, but we've had some doozies where it's just been one storm after another. People are just starting to recover and then they get hit again. So that certainly is a risk factor for anybody. Then lack of resources, in particular social support. So that can be financial resources. Having money, doesn't shield you entirely from disaster losses, but it sure helps. It's going to determine where you live, the quality of construction you're living in, how much insurance you have, all of those things that are potentially buffering or protective factors in terms of shielding you from the worst of the experience and then recovering from it. And just, we know social support. If anyone's taken psychological first aid with OMH, we just constantly emphasize that. People who have people in their lives who they can turn to, both for practical help, financial support, but just that emotional support is super key. And unfortunately, as we also, I'm sure all know, and I'll come back to this point, once people get into older age, later in life, very often that their social connections many of them have died away, or they might have moved away from them. So, a lot of older people are really dealing with isolation. So that is certainly something to be thinking about. And then just this general idea of membership in a high needs population. And that, I'll give a little teaser. We're going to do a training specifically on high needs populations in June as another special topic. But basically, these are just groups who, for whatever reasons, demographic factors, other factors, just, as I keep saying, tend to have more needs, exactly as it says. And the main point I want to make here is, with this, psychologists would call this a mediated relationship. It is absolutely not that being an older adult or being someone with a physical disability or someone living in poverty, whatever group we're talking about, it is not that membership in that group automatically means you're going to have that more intense negative psychosocial reaction. It's the fact that membership in those groups tends to be associated with these kind of middle level challenges. So many people in these groups don't have that great a support system. Either they never had it to begin with, or, as I just said, for the older adults, maybe some of those people have passed away or no longer are available. As I just said, they're more likely to have that increased dose, which, as I've already made the point, is likely to lead to worse reactions. And then, once again, the limited recovery resources. And just like I just said, that's both financial and social resources. So these are the factors that produce that vulnerability or those worse reactions. So if we can help people with that middle level, we can't make someone not be an undocumented immigrant or, won't go there. We can't make someone not be an older adult, but maybe we can help them with that middle level, those mediators, thereby trying to reduce the reaction that they are actually going to have. Okay, I hope that all makes sense just in terms of all disaster survivors, but I think you can imagine older adults really, really are susceptible to all of these particular kinds of vulnerability. All right, so turning now to just general characteristics of older adults, and some of this I'm sure will not surprise you, but just looking at this at kind of that population level. So I'm sure everyone is aware that we, the US and globally really, we are in the midst of a rapidly aging population. A lot of that is due to the baby boomers, that big swell of births post World War II, now getting into what is generally considered older age. So this is, it's great, people are surviving illnesses or life conditions that previously would have prevented them from reaching older age. I have a huge amount of respect for older people. And so I think it's wonderful that we have this population growing, but I also am terrified that we are not prepared for them. The healthcare system is not prepared for this population to be increasing. Disaster preparedness, I don't think adequately accounts for them. So, they are a blessing, but we need to do a lot better in terms of making sure we're ready to deal with their specific needs in daily life as well, certainly in times of disaster. Okay, so just in terms of categorizing, thinking about who are the older adults who we might need to be responding to in times of disaster. You certainly can think about it just in terms of age range. So people use different language for this, but the young old, that's basically the baby boomers who are now entering kind of that stage of life, the aged, and then the oldest old. And as it said on the previous slide, it's the people age 80 and over who are the fastest growing population, which kind of blows me away. So this can be useful to think about just in terms of what, again, psychologists love jargon for things. So we would call a cohort effect or a generational effect. And that is basically the premise, if people aren't familiar with that, that people who go through certain life experiences kind of at the same age, that generation, that tends to shape their attitudes. And in particular, in this regard, think about sort of the silent generation, the oldest old. Those were the folks who really kind of came up through the Depression. That was what would have been, my grandparents are long gone, unfortunately, at this point. But that really shaped some of their values. They went through World War II. The oldest old tend to have a lot of emphasis on independence, on not being perceived as dependent, on not seeking help. And really, I think a big factor to be aware of is just the shift in attitudes towards mental health issues. It's really kind of pretty linear at that population level, where there remains for many older adults stigma about acknowledging any kind of mental health concerns. That just wasn't done. It was seen as shameful, or, I'm not crazy. So much more reluctance to kind of acknowledge for some older adults, again, many exceptions, when they are kind of in distress or could really benefit from some help. Baby boomers tend to be much more receptive around mental health issues. And so, that's just kind of something to be aware of. What is the actual age of the person that you are dealing with? And what does that mean in terms of how likely they are to seek help if they need it and accept help, even if they really do need it? For our perspectives in terms of helping people, it is much, much more useful to think of them in terms of these functional categories. So, the well elderly are people who are potentially living independently. They're not in an institutional setting. They are coping fine. I would describe my 82-year-old mother is well elderly. Her knees are shot. She can't run anywhere. But other than that, she's perfectly capable of taking care of herself, making her own decisions. So that is not going to be someone that we're going to worry about as much. But of course, unfortunately, aging often comes with a lot of increasing health issues, cognitive impairment. Again, I'll come back and unpack all of this in a moment. But basically, it's these kind of frail elderly people. These are the ones who are already potentially struggling, already maybe dependent on other people for support, maybe already living in that institutional setting. But they have that limits on ADLs, activities of daily living, which means they're probably already kind of struggling to begin with. And then the disaster comes along and puts them into this really difficult position. Okay, and then the other point that we just always want to kind of remind people of is that idea of intersectionality. I don't know if any of you have taken the class. I'm not even remember what it stands for. Anyway, OMH really likes to focus on this idea of identity and what goes into cultural values and all of those kinds of things. So just a reminder of that age is just one part of what drives a person or determines what their needs or their values are going to be. And sometimes age might feel more salient for them. If they are in a situation where they're among the oldest person or they're feeling like their age is preventing them from doing what they need to do, that might absolutely be a factor that is going to impact what they're going through. But we always want to remember, again, age is just only one part of the entire picture of that person and what their needs and what their experiences are going to be. Yeah. And again, each of these elements really kind of ebbs and flows over a person's lifetime or depending on what situation they're in at that point. So just always want to keep that factor in mind. Perhaps more relevantly in terms of thinking about helping people in times of disaster, these are just some of those issues, even if someone's in perfectly good health, that they still might be dealing with some of these other aspects or other problems as well. So economic status, I mentioned this briefly earlier, but some older people have plenty of money. Even that's not going to protect them from everything they're going through, as I said before. But a lot of older people are living on a fixed income. Maybe they've got a pension or they're living off savings or certainly government payments, government assistance, things like that. But we definitely know lower economic status very much associated with ability to prepare for disasters and, as I said before, ability to recover from them. Mentioned the social connectedness already. Once again, that idea of many older people being isolated, and that has kind of the emotional impact that I talked about before of just not having someone to turn to, but it also just can have practical impact. Is there someone who can help them make a decision about whether to evacuate or not, and then provide the practical help in accomplishing that evacuation? I'll come back to that in a moment because evacuations for older adults are really, really difficult in many cases. Is there family support or is there conflict? Because it's so common in American society these days for adult children to move away from where they grew up, high levels of people just traveling around, going to different states, different locations. That means even if an older adult does have adult children they can rely on for assistance and support, maybe they are living far away and aren't able to do the kind of practical stuff, the in-person needs. Maybe there is conflict about that. Or the flip side of that is sometimes maybe the adult children have moved away, and then as the parent is aging, they then relocate to be near the adult children, whether they're living with them or just kind of nearby, which can be great if that means they're getting that support from the adult kids. But it also means now they have left their whole social network of friends who maybe they had been living with. So it's really difficult. And you can imagine how that feeds into that kind of isolation or feeling just alone and unable to get the support needed. Certainly people's cultural and religious influences. I was talking before about those issues around stigma. Unfortunately, some religions stigmatize mental health issues still. Some people from certain racial or ethnic groups may be very hesitant to acknowledge what they are going through, particularly to someone from outside of that group who they think is going to be judging them or taking advantage of them in some way. Now, I should say, for many older adults, more older adults remain religious and actively religious than younger people. That's another of those demographic shifts I'm sure we're all aware of. And churches, synagogues, temples, whatever it might be, those can be really great sources of support and community, especially if they include younger members who are willing to help out some of the older people in the community. So that can be very protective. I definitely don't want to imply religion is bad in any way in this, but it does, shape sometimes, as I keep saying, how people might feel about interacting with others and acknowledging their distress. And then just the idea of access to social determinants of health. These are things that just kind of mean, can somebody have a healthy lifestyle? So things like, do they have access to fresh and healthy foods? And that, even if something's available in a community, if a person can't get to it, if a person can't drive, can't go to the grocery store on their own, how are they feeding themselves? Can they get outside? Is it safe for them to go out and get some fresh air and some sunshine? All of these are things that are present even before disasters, and then really can, once again, kind of either set the person up to be already kind of higher needs, or then get activated in times of disaster.
Carla, can I interrupt with a question?
Yes, you can. Thank you.
Thanks. So Phil is asking, can you speak about the intersectionality and or impact of older adults' willingness to thrive after a disaster? So their willingness to thrive after a disaster.
That's an interesting question. Let me think about that for a second. I think I will come back later to some of the sort of barriers for older adults coming back from certain events. But to me, resilience is such a hot topic, and even post-traumatic growth. We talk about this a lot in like some of our other trainings. And that tends to be, so I should give definitions of this briefly. So resilience, we can think about that as, some of you've probably seen me do this hand motion before. People have whatever their baseline level of functioning is before the disaster. For some people, it's going to be very high and solid. Some people are already struggling. But whatever that level is, then the disaster happens, or the other stressful or traumatic event. You can either think of people as having an increase in stress, which hopefully over time they gradually get back to that baseline level. Or you can think of it as a decrease in functioning, because we know going through a traumatic experience really kind of rocks people's worlds, physically, in terms of health, in terms of cognitive functioning, in terms of social functioning, all those different realms where people have reactions. So people talk about resilience in different ways. I tend to define it as the people who can kind of go through that and really not have the huge spike in stress or the huge decrease in functioning. There's going to be a little bit of post-traumatic stress reaction typically, but people who are resilient can kind of get back from that pretty quickly. Some people not only get back to baseline, but actually achieve, now we'll talk about functioning, achieve higher levels of functioning in some aspects of life. So things like appreciation of life, social connectedness, once again, spirituality, things like that. And all of the research on both resilience and post-traumatic growth finds that one of the real factors that predicts that, particularly resilience, is people who George Bonanno is kind of the main guy who researches resilience. He describes it as hardiness. People who just kind of have that ability to kind of take things in stride. Not that they're not untroubled by them, but this is really people who can just kind of find, I hate to say a silver lining, but and find positivity in even negative experiences. And just kind of a stable, non-anxious personality is also associated with resilience. So to me, those are factors that kind of cross, they are really kind of, not necessarily tied to age. I'm thinking of, this is not a disaster scenario, but I've been a hospice volunteer for 25 years or something like that, and recently lost a patient who I was very, very close to. This woman had been through everything. She had lost a child. She'd had multiple health crises. She had been through a lot in her 88 years of life. She was the most cheerful, optimistic person I've ever met. It was just her personality. So I don't know if this is kind of answering the question, but I think that some people can just kind of find a way to keep going, put things in perspective. I think that's something many older people are great at, just recognizing this is a wobble in life. This is not the end of things. I will come back to that because that's not always going to be the case for sure. But to me, that is really more kind of personality driven. And certainly we could try to foster that for people, but might not be so manipulatable through interventions, I would say. I don't know if that answered the question. I will have to give that one some more thought, but thank you, Phil, for that. Skip, if you want to jump in, if you have anything to add that's more rational than what I just said, please go for it.
No, please continue. Thank you.
Okay. All right. So just, unfortunately, aging very often comes along with losses. It comes along with gains as well, but certainly our bodies were not necessarily evolved to live for as long as modern medicine is allowing many people to live. And so these are often factors that existed for aging people even before a disaster strikes, certainly less mobility, less agility, balance issues, just the kind of wearing away of body parts and body functionality. So also sensory limitations. A lot of older adults experience loss of hearing, and some of that's sort of environmental, depending on what their work or their entertainment practices might have exposed them to in terms of loud noises. But some of it is just kind of erosion of that fineness. Visual impairments, loss of sense of smell is very common in later life. I'll come back to that. And so those can just kind of limit those activities of daily living in some cases. And then chronic medical conditions. And some of those are things that might require steady, regular access to medications, whether that or to treatments. I can't remember the statistics, but there's all the stats that like adults over the age of 65, I think the average is to be on like 3 to 6 prescription medications on a regular basis. So people often are dealing with medical demands to begin with, and as I keep saying, then that's going to get exacerbated. And another, really important issue around disasters, particularly when we're talking about large events that are just going to disrupt conditions for some time afterwards. Are people needing dialysis they can't get? Are people needing, there's so many cases talked about after Hurricane Katrina, because people got displaced so widely and so many medical records were lost, of people who had been in the middle of chemotherapy or other treatments for cancer, who basically just kind of had a pause put on that treatment, which for many people, by the time they could get that started up again, really probably shortened their lives. So these are just, these factors could occur for younger people as well if they're already dealing with medical issues, but certainly complicating factors in times of disaster. And then psychological factors, which are often overlooked or downplayed among older adults. And part of that is by some of the older adults themselves, but also by those around them. And I think that kind of just factors into how we tend to view aging and later life stages in our society. I think there's not a whole lot of respect among many people for older adults, for their strength, for their wisdom, for the skills that they have gained throughout their lives. And so I think sometimes there can be a bit of a tendency to think, well, of course grandma's depressed, half of her friends have passed away and she can't get out the way she used to and things like that. So I think some of these conditions certainly could be addressed and could be treated much more than they are. I think far too often they're just kind of like written off as just part of older life and not addressed the way they could be. Substance use disorder is a real problem for a lot of older adults. Not so much illicit drugs, street drugs, but certainly there's high risk of misuse of prescription medications, particularly things like opioid painkillers and then benzodiazepines. A lot of older people get put on anti-anxiety medications, and sometimes, even if they're following them as prescribed, there can be real issues with drug interactions of, they're taking the benzodiazepine and I don't actually know what would cause an interaction, but, a heart medication or something that can kind of heighten the impact of the benzo. And then, of course, those, both benzodiazepines and opioids, those can then be associated with things like poor balance, sleep disturbances, higher fall risks. So just, so much of these factors are just kind of those ripple effects of one thing happens and then another thing happens and another thing happens so often. I mean, back to the physical symptoms, I'm sure we've all known someone who just had that classic example of they fell and broke a hip, and then they were bedbound, and then they declined, and then they got pneumonia, and then they died from that. That was exactly what happened to my hospice patient, and it was awful because that was exactly what she didn't want to happen to her. So anyway, issues around all of these things. Also, alcohol misuse is not uncommon among older people, especially older men. And then just, grief. Grief is not a disorder, but it is a part of life, especially if you have gone through multiple losses. And that can be losses of people, but that also can be loss of feeling, motivation, loss of grief over having retired and lost the excitement of feeling like a valued citizen in the world. All sorts of different forms of grief connected with lower self-esteem. We just infantilize older people so frequently, drives me nuts. But we make them feel like they can't do anything, and we don't let them do anything. And so of course that's going to impact someone's self-esteem. Talked about anxiety before, not uncommon. And then cognitive decline, that can take so many different forms. Obviously at its most extreme, that will be something like Alzheimer's or other progressive dementias. But it can just be that kind of loss of quick thinking. It gets harder to learn new things as we get older. We are slower to pick up on skills. We often have memory impairments, particularly short-term memory. A lot of older adults can remember everything from 50 years ago, but have a hard time retaining information that they have learned more recently. I like to think that in many cases, that slowing potentially or lack of flexibility in thinking is offset by that idea of wisdom, of having deeper insights into the world and how people function, but that's not always recognized for sure. And of course, cognitive decline can be very serious if it is not just the kind of mild slowing, but an actual dementia. So those are all just kind of pre-existing things that many older adults were already potentially struggling with or grappling with, and maybe doing fine. Maybe they were doing okay as long as they were kind of in their own home or in the care setting that they were living in. Things were predictable, things were routine, but now you disrupt all of that with the disaster approaching, and this is when it really gets very hard for a lot of older people. So I'm going to talk about this kind of across the disaster cycle, so the before, during, and after a little bit, and then what can we do to help people. So before an event, does the person do they get the warning? I will, again, my 82-year-old mother, sharp as a tack, perfect memory, perfect cognition. She only gets information from television news and the newspaper. And so if there is something that's coming that doesn't have a 3-day warning period, and I don't call her to give her a heads up, she's not going to get that warning. And she's not going to be able to do whatever she might need to do and might be perfectly capable of doing. So, I think there's so much emphasis now on using technology to disseminate warnings. And whether that's by text or email alerts, and that is great. It can push information out incredibly rapidly to targeted areas. Technology is amazing, but I worry that we are so dependent now on this that we've kind of lost the backup systems, the belt and suspenders of making sure some of the most vulnerable people who really need the most lead time to make decisions around disasters are not going to get it. So issues around technology for sure. Does the person understand the warning? Some of the language is very jargony, assumes some pre-existing knowledge. So, do they get it? Can they retain it? If someone does have a bit of short-term memory issues, they might see something on the news and then basically move on to the next thing and forget that they had received some kind of warning. And then, are they willing to comply, and are they physically capable of complying? I should say those questions are really specific to people who are living independently. If someone is living in a nursing home or another kind of rehab center, care facility, something like that, they don't have a choice in the matter, right? If that facility is evacuating or sheltering in place or taking whatever action is needed, they are going to have to do that, and that can also be problematic. Theoretically, in that case, there are professionals who are following a careful plan, taking care of them, seeing that their needs are going to be met. But there again, that loss of control, that loss of power over what happens to them, that can be very upsetting as well, even if it's maybe not as like life-threatening as someone having to make a decision on their own. So evacuation, total potential nightmare when we are dealing with large groups of older adults. So certainly many people who are not in a care setting, an institutional setting, a lot of older adults don't drive, don't have transportation, so they might need to have someone bring them somewhere, bring them to a shelter, whatever the setting is going to be. Certainly for a lot of older adults, that fear of separation, and particularly with pets. I mean, I think we recognize this with everyone now, and there's so much more that goes into planning for how people can safely shelter their pets if they have to, go to a Red Cross shelter or something like that. But for some older adults, their little dog or their cat might be sort of their only family, their closest companion. And if you tell someone you can't bring your pet with you, they're not going to go, right? They're going to say, I don't care, I'd rather die at home. So that can become very difficult to convince people. And also, for a lot of older adults, their possessions, it's a lifetime worth of mementos and photos. And especially if their photos are in their albums and they're not in the cloud backup, which is likely to be the case, just to convince someone to kind of walk away or roll away from all of that stuff, knowing that they might not be able to get back there, just incredibly hard for anyone, but for older people especially. And the evacuation process itself, especially for frailer, older people, people with a lot of medical needs, people who need oxygen tanks or things like that. I don't know if people are familiar with this term of transfer trauma, but this came up in New York State. I wasn't directly involved in any of this, so I kind of heard this secondhand from people who were involved. But my understanding is when Hurricane Irene was approaching, I think that's 2011, I want to say. Originally, Irene was predicted to hit the New York City area really hard. It ended up kind of rerouting and hitting up near me, kind of the Hudson Valley, Catskills area, much worse than it actually hit the metro area. But because it was predicted to hit New York City and all the boroughs, there was, my understanding of this, and if anyone knows more on this, please put it in the chat. I'd love to get corrected if I'm wrong about this, but there was a mandatory evacuation notice for all of the kind of low-lying nursing homes and hospitals. And during the process, my understanding is that came from the New York City Department of Health, I think. During that process, several of the older residents who were getting relocated to other care facilities died just because they were so fragile, and just putting their bodies through that, it was just more than they could handle. So then when Hurricane Sandy was expected 2 years later, I think it was, the authorities decided not to have that mandatory evacuation order because Sandy was the opposite. It was supposed to hit farther north, ended up slamming the city, as I'm sure everyone is aware. And so then they ended up having to do evacuations like during and just after the storm, which of course was even harder. So this is not an easy thing for people to have to make decisions about, but just being aware of the fragility and the toll that just that process, even if it's necessary to save people's lives, that can take. And then the fear of shelters and other unfamiliar settings. This goes back to what I just said before. Maybe someone knows that they can function okay in that predictable, quiet setting, but they know a shelter is going to be chaotic. They know it's going to be, noisy, uncomfortable. Those cots, I don't know if any of you have ever laid down on a Red Cross cot, the ones that are like the green canvas stretched over the metal tubing. They are not comfortable for anyone. I cannot imagine for anyone with mobility issues, back issues, anything like that. So just that fear of what they're going to experience kind of short term if they leave, and then what's going to happen if they agree to go. Are they going to be able to get back home again? What is that going to look like? What are those losses going to be? So as I keep saying, these are things that are scary and difficult and painful for everybody, but particularly for people who maybe don't have that kind of flexibility, don't have that kind of belief that they are going to be able to adapt to what they might be going through. Okay, and then post-impact, say the person, whether or not they had to evacuate, say they are able to get back home, again, to, if they're living independently, just all of the things we say, like, have a used to say 3, now I think the recommendation is like a week's supply of food and water and medications and batteries and, all the other essentials. Well, first of all, that stuff can be expensive to stock up on. That the older person might not have had an opportunity to go panic grocery shopping like I'm sure everybody did on Friday and Saturday before the snowstorm just hit. Things are heavy. Think about like a jug of water that you might need to stockpile the water. Can a person lift that? Do they have the medications? All of these kind of basic things. If someone needs medical equipment that is powered by electricity, are they going to be able to get their power restored quickly enough to run an oxygen tank or a powered wheelchair or whatever it is? I mean, hearing aid batteries, even things like that. Certainly, older people have less ability to tolerate extremes of heat and cold, particularly heat. Older people are very, very prone to hyperthermia, and I always get hyper and hypo confused, to overheating. Partly that is because some of the medications that are common for older adults to be taking actually can increase their sensitivity to heat. So they're kind of already starting off at higher risk for that. And then a lot of older adults just don't hydrate the way many younger people do. It just wasn't the cultural norm to be told to drink 8 glasses of water a day. For some, it's simply because they don't want to have to go to the bathroom frequently if that's difficult for them. So a lot of people are already borderline dehydrated, and then you add extreme heat on top of that, and they can very, very quickly get into serious trouble in that way. Can they recognize unsafe conditions? Some of this is kind of a silly example, but I mentioned before, a lot of older people lose the acuity of smell. So they can't detect odors as strongly as before. So does that mean maybe there's a gas leak? Can they detect that and know that they shouldn't light that burner? Can they smell if food has gone bad in a refrigerator that has not had power for 3 days? Even just things like, this isn't really unsafe conditions, but I always think about this, like, thinking about, when my grandmother was in her 90s, she had arthritis in her hands. So she lived independently for quite a while, but, she used an electric can opener to open her cans. Someone might have supplies of food, but not be able to access them. So it's just all these things that we don't necessarily kind of think through. And then the last point, being targeted for a scam. Always after disasters, you hear those horror stories of someone just, stops by the house, says they're a contractor, and just, give me all the cash you have in the house and I'll go to the hardware store and get the tarp to fix your roof up. And far too often older adults fall for it, not because they're foolish, not because they don't have good judgment, but because they just want it to get fixed. They know they can't do it themselves physically, and so they'll kind of take that risk, and there are way too many people out there willing to take advantage of them in that regard. Okay, so our next section, just make sure I'm not forgetting anything I wanted to say, is, so what do we do for this population? Okay, so
Carla, can I just interrupt to make sure that at some point you address a question that came up around how to treat folks or how to support them. This is another question from Phil, and it is, do you have recommendations or suggestions on the benefits of cognitive restructuring during and post-disaster recovery? Maybe looking for some best practices. So cognitive restructuring after disasters and its benefits.
Okay. Let's see, can I come back to that at the end?
Of
I want to make
course.
sure I kind of get through all of
Yeah,
the content, and then
of course.
I will come back to that, I promise. And hopefully I'll have an answer for you by then. Okay. Okay, so what do we do? So I kind of mentioned this before. Most of the evidence, most of the research suggests that older adults don't necessarily or aren't at higher risk for extreme reactions like post-traumatic stress disorder. However, we were sort of talking about this with the team, older adults often kind of struggle with change, struggle with disruption, all the things I was just talking about with if their routine gets disrupted, if they have to relocate for a period of time. This is certainly something I've seen a lot. See it in my own mother occasionally, some of my hospice patients. There can be a bit of a tendency to catastrophize, to ruminate, to really like dwell on things that maybe a younger person would have more the attitude of like, okay, well, this is not fun, this is not what we want to be doing, but we will get through it. Sometimes that can be a lot harder for older adults just because they're maybe already kind of struggling a little bit to just kind of keep up with those daily living things. So we certainly want to expect some real short-term stress, distress, suffering for sure, that we absolutely want to support people with psychological first aid and other just basic forms of support, connecting them with their support networks, et cetera. Also, I feel like I've made this point sufficiently, but some older adults might be feeling that distress, but not acknowledge it just because of stigma, because they were raised that it's not appropriate to talk to strangers or outsiders about this kind of thing. So all the stuff I started off talking about. And then just, we certainly know that point from the very beginning, likely to have less of that support network, financial strain. And so that can feel, if someone's really struggling to get by financially, then having to do repairs can just feel overwhelming and completely more than they can just begin to tackle. And this, I think, is such an important point to keep in mind. For younger people, yes, it's awful to lose your home and everything in it and have to rebuild or whatever the particular experience was. But there is that sense of, okay, this is a setback. We can rebuild, we can relocate, we can start over. Someday we will get back to that new normal, that place of happiness again. And for older adults, that might not feel available to them, and that's realistic. We need to not downplay that. I don't have a great answer for what to say about it, but validating that is an actual concern for them or an actual major barrier to recovery. We know from psychological first aid, one of the most important things is helping people have a sense of hope, right? If you don't have any kind of hope that things will, maybe not that they'll be the same as they were before, but they will get better again, how do you keep moving? And that can be really hard to kind of help people find that hope if they understand that realistically, it's not ever going to be the way it was before. So that's a very challenging thing with this population. Okay, so how do we support older adults? First of all, really taking that practical approach, addressing what the physical needs are, getting them restored to whatever medications they were on, and just trying to get them to as stable a situation as possible. And maybe that means that they are able to go back home if they'd had to evacuate. Maybe they're able to go back to their facility if they were in an institutional setting where at least it's what they were familiar with and they know the routines and they have their stuff and all of those things. Sometimes that's not always going to be possible. And sometimes, what's my train of thought? But just really making that the ultimate goal. And certainly probably first thing on here should have been attending to medical needs, trying to find out what medications they were on or what treatments they needed to receive. And that can be really tricky because, we all know if you have to evacuate wherever you're heading, bring that supply of medications with you. Well, not everyone has the time to do that, the wherewithal to do that, the planning, et cetera. And just thinking about, as I said before, many older adults are on multiple prescription medications. And if you ask them, they're not necessarily going to be able to rattle off, I take this one at 8 o'clock in the morning and I take this many milligrams of this one at noon. So just tracking down what medications they're on can be super challenging. adapting shelter conditions to accommodate them as much as possible. And some of that, you're going to be limited by what that physical space is, but some of that might just be having kind of, if you've got a huge congregate setting in a high school gymnasium or something, can you have a section off to the side that is only for older adults, that children are not allowed to go and run around in, just whatever you can do to make it as quiet and least chaotic, least distressing as possible. But there's always going to be limitations there. Also, I mean, just things like, if feeding involves standing on a line to go through a cafeteria setting or something like that, that might be really hard for an older person to do. So can you get volunteers to bring them a plate so that they don't have to go through those physical demands? Just, anything you can think of that's going to be helpful in that way. Breaking demands down into smaller, manageable pieces. This really goes back to what I said before about not necessarily having that kind of flexible thinking or getting into that catastrophizing, getting into that all or nothing kind of thinking. And I think that really kind of ties back, and I will get back to the cognitive restructuring, but to me, that's kind of a key part of that. I often, again, some of you may have heard me do this in other trainings, but I always say, like, when I'm super stressed, it's like, here's me and here's all the things I need to do, and there's just a brick wall in front of me, and I cannot see anything but the brick wall right in front of my face. And so sometimes what we can do in trying to help people, anyone, especially older adults, is just break that brick wall down into manageable pieces. So, example of this is, say someone is in an emergency shelter and they're wondering if they're ever going to be able to get back home and wondering if they're going to be able to rebuild. And that is overwhelming them, understandably, for sure. Breaking it down, helping them prioritize, helping them think, okay, you don't have to make decisions about any of this right now until you have the full information, which will not be available for a few days. We do know that this shelter is going to be open as long as necessary. I'm going to help you start the process to, submit the paperwork with your insurance company, whatever it is. Just, again, breaking it down so that they can start to kind of see a path through the different piles of bricks. They're still going to have to deal with them, but maybe it's not going to be quite so overwhelming in that way. And then the last point, this goes back to not everyone's, some older people's discomfort with using technology. If my mother does not use a smartphone. If she had to submit insurance forms using technology, she would be completely overwhelmed and frustrated and upset and feel abandoned and all of those things. So I think that's, again, such a small thing, but seeing what people's tech needs are, what their administrative support needs are, and helping them kind of tackle those needs so that they're not just feeling like, I can't do this, and then they don't get the support or the financial compensation that they might be entitled to. So practical needs first, emotional needs as well, and those two certainly can be intertwined with each other. But connecting with a positive support network if they have one. And this, I've never seen this in person, but I've heard stories of this, of maybe the older person had been still living independently and now they've been displaced or their home has been damaged, and the adult child basically uses that as justification. Like, look, mom, clearly it's not safe for you to live on your own any longer. We're going to have to see about either you moving in with us or moving you to a facility or something like that. So sometimes people don't want to reach out to their support networks because they know they're going to get either blaming messages or be presented with outcomes that they are not interested in. Certainly doing outreach, particularly if you know that there's a neighborhood that maybe has older adults who did not evacuate. Either they couldn't or they refused to. Knocking on doors, depending on what your role is, obviously. Talking to people if you have them in a shelter or setting like that. Looking for people who are alone or isolated or might be dissociating or things like that. And you want to respect people's autonomy. If they say, I'm fine, I don't want to talk to you, hopefully not quite that bluntly, that's okay. Maybe circle back a few days later. I think I have time to tell this story. One of my colleagues, actually Rick King, who retired from OMH few years ago, who some of you might know, super experienced disaster responder. He told me his amazing story about he was in one of the shelters in the Gulf Coast after Katrina. I think he was maybe in Baton Rouge. And he said there was an older man there who was on his own, really didn't interact with anybody else, didn't want to talk. But Rick said he learned every day the man wanted to get the newspaper so that he could check the sports stores. And so Rick kind of made it his routine the time he was deployed there to just kind of circle through, hand him the newspaper, ask how he was doing, see if he wanted to talk, and then respectfully move on. Same thing the next day. Rick said on I think it was the last day he was deployed, he gave the man the newspaper. It makes me choked up for some reason. Asked him how he was doing, and the man finally patted the cot next to him and invited Rick to sit down and talk to him. So it's that kind of thing, probing but not pushing, and once again, respecting autonomy. And then being patient, all the things I've been talking about with cognitive, I won't even say impairment, but just that tunnel vision, catastrophizing, all of those things, recognizing they're not doing it to be challenging or to be difficult. They're just really struggling cognitively with how to process what they have been through. And then certainly involving them in planning, for sure, if possible, if you're involved in making community plans in advance, involving them in helping other survivors. The whole from the disability rights, nothing about us without us. Maybe there's a role in a shelter they can take. Maybe they can do some of the outreach to other older people in their community. Whatever it is, just to remember they do have skills and they do have value, even if they're struggling themselves. These were some tips from SAMHSA. I know I'm quickly running out of time. We thought these were really good, and you can find these on the SAMHSA website. So just, talking to them, and, I'm sure we all know this, but often you start with, do you have medications you need? Do you need clothing, whatever, using the tangible stuff as kind of an entry point into then maybe getting into more emotional mental health needs. I always like questions that remind people they do have skills, they have been through difficult times before. So here are some questions, often recommend asking, when have you been through something like this before, and what did you do? It kind of reactivates that sense of agency or self-efficacy potentially, and also just gets them talking, which is good. Listen to their responses, actually listen. Once again, sometimes there's a tendency to kind of talk over older people or tune out, so learn what you can learn from them. And then really being tangible in that guidance, which I think just goes back again to that break down the brick wall, make specific suggestions. We're not talking about counseling here. We're talking about helping them find the resources that they need, making sure they have the information that would actually be helpful for them. And finally, basically, again, just recognize what they have been through, recognize their strengths, that they do have typically that kind of resilience. And, for many older adults, if you can address their physical needs, their medical needs, their sheltering needs, if you can do that, hopefully that natural recovery process gets activated, and then they can cope as well as possible with what they've been through, while also acknowledging they might not have that longer term perspective on recovery. And we also just need to acknowledge and validate that for sure. So that is basically it. I see Skip is dropping a bunch of resources for you into the chat. So these are just a bunch of websites and publications we found. So these are mostly New York City focused, though certainly a lot of this would apply throughout New York State, some of these resources. And then some state and federal resources. Ready.gov is kind of a good clearinghouse through FEMA. And so all of these hopefully will be a bit useful for you. And that is it. So I will stop sharing, if I can find the right link on that, and attempt to go back to that question. Let's see.
What great timing, Carla.
I'm a pro.
Perfect. One thing we noted in the chat as we were discussing the question is that, of course, typically we would be providing non-clinical approaches during disasters, at least from the psychological first aid perspective, so that perhaps the cognitive restructuring piece might be something that, part of the referral process or into a more clinical environment. But, feel free to address that if you'd like.
Yeah, no, I think that's a good way of thinking about it. Generally post-disaster, we're really thinking about psychological first aid, about that kind of supportive attitude, helping people just kind of, pick them up and brush them off and get them whatever they need at that practical level. Certainly cognitive restructuring is a major part of cognitive behavioral therapies, particularly cognitive processing therapy, which is highly recommended for post-traumatic stress disorder. But yeah, I would say that's probably not kind of, as you just said, Skip, kind of the immediate focus right after disaster. But if someone is working with people on a longer term basis, that would certainly be useful. Yeah.
Thanks. Carla, I think I'm going to have us pause for the moment so we can end the formal presentation and stop the recording. We just want to thank you for your presentation today and all of your expertise. We value you so much, and we come back to you time and time again for these, and we're very grateful for your commitment to the program. And thank you to all of you who joined us today. This will be available as a recording. You see some resources in the chat. You're welcome to grab those, and we'll stay for questions as needed. Okay, so stick around if you have questions, and we can unmute and do that. But we'll stop the recording now.